Coming up today, a new option for migraine, the first nasal spray of its kind. We meet one of the scientists who created it and learn how it fits into the bigger picture of a more complex disorder. Good morning, I'm Jessica Lovell. Welcome to the Morning Medical Update. Migraine is not just a bad headache. It is a disabling disease that is often under-recognized and undertreated. But it's common, affecting 1 in 10 Americans, according to the American Migraine Foundation. Thankfully, though, treatments have come a long way in recent years. And that includes a new nasal spray, gpant, sold under the name Zavspread. The FDA approved it in March, and it's supposed to be available later this summer. It works by blocking a certain protein in the brain called CGRP. And in a clinical trial, it did better than a placebo on several measurements, and that included pain relief in just 15 minutes that lasted up to 48 hours on a single dose. We're learning more about the drug and how it fits into the existing range of migraine treatments from 2 of our headache experts here at the health system. Both are neurologists. Dr. Sarah Hahn is here right next to me. She is also Vice President of Neuroscience. Good morning. How are you?
Good morning. Thank you. I'm fine.
Good to have you. And you know Dr. Dietrich Ford, Division Chief, it's Monday, Division Chief of General Neurology and Director of Outpatient Neurology Clinical Services. Dr. Ford, how are you?
Doing great. Thank you.
Oh, gosh, this affects so many people, so we'll have a lot to get to today. We're also joined by Dr. Charlie Conway. He is a biologist who helped discover and develop the new drug, gpant. He calls this drug one of his babies. Dr. Conway, good morning, and I'm going to rely on you to pronounce this for the rest of the morning. Is that okay?
Well, yes, absolutely. Thanks so much. It's a pleasure to be here. Thanks for inviting me. The scientific names can be a mouthful. You said it perfectly.
Thank you. It's a big one for me on a Monday. So good to have you. We're going to talk more with you in just a moment. But Dr. Hahn, let's just start by establishing what are migraine symptoms, because it's not just limited to that headache that we think of.
That's exactly right. So migraine really is a brain disorder. You could even say a disease. As you've already said, it's super common. 12% of the population has migraine. 18% of women, amazingly, have migraine. So it's super common. Migraine is typically characterized by migraine attacks, which usually are characterized by moderate to severe headaches, often throbbing or sharp in quality, typically nausea, sometimes vomiting, photophobia or sensitivity to light, phonophobia or sensitivity to sound, definitely can be components of migraine. Often they're pretty incapacitating. They can be one side of the head or both sides of the head. And then some patients have what we call an aura. So usually the aura, if it's experienced, comes before the headache. Typically can be, visual symptoms, can be sensory symptoms like tingling, or can even be speech disturbance, like difficulty coming up with your words sometimes. Only about 25% of patients with migraine have aura, though. So one of the common misconceptions is that if a patient has a really bad headache and they don't have an aura, it must not be migraine, but we know that's not true.
Interesting. And all of that sounds very familiar because I fall in that 18%. So I'm going to run down I have a couple of questions for you myself. So Dr. Ford, there can be different migraine diagnoses. Migraine diagnoses, they depend on 2 factors, chronic migraine and there's episodic migraine. So what's the difference?
Yeah, so it really comes down to numbers at that point. And so the chronic migraine number is really 15 migraines per month or more. Episodic we consider less than 8. And between that 8 and 15 is kind of a gray zone depending on what your headache types are like. But it's actually really difficult for people to sometimes identify what's a migraine and what's just a headache. So we really break it down into headache days and migraine days, and then how long do those migraines last, because someone may have a migraine that may last up to 72 hours but not count it that way.
And I want your thoughts on some terminology. A lot of people say migraines. I suffer from migraines with the S, but I notice many doctors prefer migraine without the S. So what's your thought on that? Why do we call it that?
Well, I think migraine is more the disorder, or even we could say the disease, where migraines, we're really talking about attacks. So like when Dr. Ford is talking about, say, in chronic migraine, where you count the number of headache days or you count the number of attacks, those would be migraines. But even if a patient has, say, 2 or 3 migraine attacks per year, they still have migraine as the disorder. Does that make sense?
It absolutely does. Let's bring in Dr. Charles Conway, a biologist who recently retired after devoting a large part of his career to migraine drug research. Dr. Conway, again, so glad to have you. So this new drug is part of a class of drugs called gpants. So what are gpants? How do they work? And am I saying that right?
Yes, no, you said it exactly right. So this is a new class of medicines. They work by blocking CGRP. Scientists call these CGRP receptor antagonists. It's like putting tape over a keyhole. If you've got the keyhole blocked, then CGRP can't bind to its receptor. And by blocking the receptor, we stop that cascade of hyperexcitability that leads to migraine, which, as you know, the previous speakers have said, it's way more than just a headache. You know, it's hypersensitivity to lots of different inputs and really debilitating. Most people with migraine can't function normally on that day.
So, Doc, there are other migraine drugs out there, but what makes this one so different?
Sure. So what makes this different? It's the first ever of the CGRP class of gpants to be a nasal spray. And what's different about it is ultra fast onset of action. So 15-minute superiority over placebo in terms of pain relief, lasting for 2 days with a single dose. And it's not just pain relief. There were multiple measures, actually 15 measures in total, where zavegepant was superior to placebo. And so it's not just about a single measure. It's about helping people get back to their lives. And so the big deal is super rapid onset of action and durable efficacy, but importantly, without medication overuse headache or a CV safety risk, which is something that's been a component that's limited the utility of triptans for many patients.
So you had mentioned the clinical trial shows that zavegepant worked better than the placebo, but it didn't work for every patient. So I want to hear from our entire panel, but Dr. Conway, let's start with you. How do you know, and how do you know you have the right patient for this type of medication?
Yeah, so when you start a clinical trial, you use the International Classification of Headache Disorders criteria for enrolling patients. And the results in this trial were very typical to the trials that have happened over the past, 30, 40 years. Around 60 to 70% of patients showed a response. And what that teaches us is that, not all patients have the same underlying disease state. And so let's say that you got a script for a new gpant and you tried your prescription, 6 or 8 doses or whatever, and it failed every time. Well, that'd be really informative because it would tell you that what you have is not underlying a CGRP hyperexcitability state. And so that's helpful for both patients and physicians. But what I would say is around 60 to 70% of patients did respond. So it's a good bet to give it a try.
So, Dr. Hahn, how do you find the right treatment for the right patient? It just spans from one end to the other. So where do you start?
Well, it's not easy, first of all. And sometimes I would say, Dr. Ford probably agrees, it's trial and error. And also the other concept I would think of is for these folks who are suffering, 90% of migraine patients suffer from some level of disability. And 1% of the population has chronic migraine, where they have headache more often than not. And so a lot of times we're using these medications in combination. And sometimes that's the sweet spot. And you just have to try different combinations until you find the right thing that works for that patient. The wonderful thing about this drug and what's unique about it is that it actually bypasses the GI system. So a lot of these folks have nausea, some of them have vomiting, they're not absorbing things through the gut very well, and this allows us to bypass that, and also with its rapid onset, hopefully catch the headache. That's one of the principles we use. The earlier you can catch a migraine attack, the more likely whatever medicine that you're prescribing is to work.
Yeah, be more effective.
Exactly. So this rapid onset, the nasal preparation, is certainly unique and an advantage.
What can you add to that, Dr. Ford?
Yeah, so from my perspective, I would agree with Dr. Hahn. It's mixing and matching. It's trying to find that right patient. I would say that something I really look at is the comorbidities of the patient. So Dr. Conway mentioned the CV risk. So cardiovascular, cerebrovascular risks for stroke. It cuts a lot of medications out. We also look at other interactions and drug interactions that can occur with medications. And luckily, this class of meds does not have a lot of those. So we are able to overall find a little bit better sweet spot for some of our patients that have a lot of comorbidities or on a lot of other medications. So this is a good place to use that as well. well.
So, Dr. Ford, what other treatments are there? What options are out there for people?
Absolutely. So we break it down into episodic, meaning very few migraines per month, versus chronic in terms of our medications. So there are prevention medications that you take every day to prevent migraines from coming on. And then there are acute medications. So zavegepant happens to fall in that acute medication. So if you get a migraine, we then recommend to take zavegepant or a triptan or some other type of gpant medication to abort the headache that you are having. And then there are prevention medications for people who are having multiple headache days per month or migraine days per month. So really divides depending on how many people are having.
So, Dr. Hahn, what is it like having medications and treatments available that just simply weren't around decades ago?
It's remarkable. I mean, I often tell people the world of migraine has been revolutionized. First by the FDA approval of botulinum toxin injections about a decade ago. That revolutionized and opened the door for a lot of patients who had suffered for decades, very life-limiting.
And tell people what those are, those injectables.
So botulinum toxin injectable is a treatment that we give to the patient every 90 days, and typically it's ongoing. And it takes a little bit to work. I often tell people, if you're going to try it, plan for a year. Because the effects are cumulative and it takes a while to really get into the system. But botulinum toxin injections can be combined, for example, with a gpant for prevention and or a gpant for attack. Can also be combined with some of the monoclonal antibodies that we have. These are typically monthly injections that patients can use. And those combinations are almost, I would describe them as synergistic, where it's not 1 + 1 = 2, but 1 + 1 maybe equals 5 or 10.
Did you have something to add, Dr. Ford?
Yeah, no, I actually agree completely. I think that has been where we've looked at the most, and I know there are some ongoing trials looking at combining some of those monthly injectables that a lot of people are on with the Botox injections at every 90 days. And so I know we all have different ways that we practice and put those together, but a lot of the time we will see wearing off from Botox or the injectables, and so sometimes staggering those every 6 weeks really make a huge difference as well. So we kind of move them into each other a little bit, and there are some other infusions that we can also include in that, Vyepti for one, and so that's another one that we'll try to taper in different areas.
I want thoughts from our entire panel about a recent clinical trial. It's the first ever head-to-head trial comparing an injectable monoclonal antibody to an oral gpant. So it's an injection versus a pill. The result came out 2 weeks ago. One headline claimed the injection flunked the head-to-head study. Dr. Ford, what did it show? What do we know?
So it was really based on the primary endpoint, showed that one of the gpants, which is an oral medication that you take as prevention, so that one's an every other day medication, versus an injectable, and it showed on the primary endpoint it was pretty equivalent, which is amazing and actually great, I think. So I don't think it flunked. I think it showed that they're both efficacious and they both are great options. I think it really makes a play for more of looking at those oral medications, because we have a lot of patients who are needle phobic who don't want a shot every month or at all. And so having an oral option's really been great, and we've had a lot of success with it. So we'd already been using it quite frequently, but I think that just added to our ability to say, hey, this is pretty equivalent and we think this is going to work.
Dr. Conway, your thoughts on the trial?
Yeah, so I think, news writers like a catchy headline, and so I think the reason that they used that terminology of flunked was because the sponsor's hypothesis was that the injectable would be superior to the oral. And really, I applaud them for being brave enough to go after a head-to-head trial. It's very unusual to do a head-to-head trial. And just like Dr. Hundreds just mentioned, there is, basically, or sorry, I think that was Dr. Ford, there's no significant difference between the two, which means patients who can't tolerate the injection or who didn't respond or are needle phobic have an option with trying an oral. Or if you haven't tried one of these CGRP blockers as prevention, you could try the oral as your first go around, and then, as was mentioned before, find the right combination that works best for you.
Dr. Hahn, how important are these trials and just us constantly bringing in new information and evaluating them?
I think they're helpful. I don't think I was terribly surprised. I don't think Dr. Ford was, because in our experience, each patient is different. And somebody might respond to one of the monoclonal injectable antibody drugs, and somebody else might respond to the gpants. So it just varies. I wasn't terribly surprised by the trial, but it's always good to have new data.
So I want to talk about this. I want to get everyone's thoughts, but is it true that many people who have migraine never seek help? Who wants to start? Dr. Ford?
Yeah, I mean, absolutely. So I think that Dr. Hahn made an interesting comment earlier that's been normalized, and I would agree with that. So one of the things that, we try to encourage people to do is if you're having headaches, talk to your doctor about it. Even your primary care doctor can address these things and try to determine what type of headache do you have, because early treatment is important. If people are not getting adequate treatment or they're treating at home with ibuprofen, Tylenol, those types of things can cause medication rebound headache or overuse headache, and then you're just putting yourself in a cycle that's even harder to treat over time. So typically we would recommend that you talk to your doctor about any type of headache you're having, even if it seems just a nuisance to you or, oh, I think it's a tension headache. A lot of the time it's more than that, and people aren't reaching out and they aren't getting adequate treatment, and then things can progress to that chronic state where it's much harder to treat.
So full disclosure, Dr. Ford is my physician, and you prescribed me a medication. I came to you with a problem. I said, I'm having these troubles. You said, let's start on this. But Dr. Hahn, I didn't take them. And you say that that's common and people just kind of live with it and normalize it. Yeah. Tell us what you mean by that.
50% of people with migraine never seek any treatment at all. And what I often find over years of practicing is that patients will often come in and describe those really severe headaches. They focus on that. And when you start asking them, what is life like in between? Well, I'm okay, I do fine. I get by with my Excedrin migraine, I get by with my acetaminophen or my Advil or Aleve over the counter. But what you find is that people have normalized headache in between, and they've learned to sort of live with these migraines and live with the headaches in between. Often in chronic migraine, those lesser headache days are still part of the migraine disease.
Right.
And people have normalized.
They're just not as bad.
They're just not as bad, and they can sort of push through.
Well, and I think the thing is, nobody wants to say they can't handle a headache. I mean, we all live with a headache. Who wants to say I have to go see a specialist for my headache? It's kind of one of those suck it up moments, do you find?
I would say that that's what we hear a lot.
Yeah.
And so what I always talk to patients about is that what a migraine feels like compared to a headache. So a headache can be really bad, it can be really severe, but a migraine is absolutely debilitating. And for someone who's had one, they understand what that means. They know that nausea, the light and sound sensitivity, the ability to just walk into a room and not be irritable, it's not there.
You lose time and you lose days. Spending time laying down, not with your family. Yeah. So it's
some studies have shown that uncontrolled migraines are the same quality of life as a patient with uncontrolled epilepsy.
Interesting.
Because you can't plan. You don't know when you can go to your kid's ball game or choir concert or band performance or dance recital. You don't know, you may have an important presentation at work. You don't know if you're going to have a migraine that day and you're going to be basically disabled to go.
So why do it? So what gives, Dr. Conway? You've done all this work. You've dedicated your career, this passion for migraines. What are your thoughts when you think people aren't seeking the right help? What message do you want to send to them?
I think the challenge is it's just the idea that nobody can tell how disabled you are by looking at you, and so you don't want to be the colleague that's not carrying their weight or whatever, and so a lot of times people just power through. But what I would say is, if you're taking over the counter things 8 to 10 15 times per month just to get through, that's not normal. And actually doing that for both acetaminophen and ibuprofen and the triptans actually increases the number of headache days you have every month. That's what's called medication overuse headache. And so you're actually doing yourself a disservice. You're missing out on things in your life that you wouldn't have to miss out on if you found a targeted therapy that worked for you. And let me tell you, what patients are telling us is that the patient experience on the gpants is so much better. They just get back to their lives. And for me, that's the big satisfaction. I spent over 23 years of my life working in this area to bring relief to the 1 billion patients in the world with migraine. And so part of participating today is to help get the word out. If you've given up, there's a new option and there's new classes of options where the patient experience is so much better. It's worth a conversation with your physician.
Well, and you mentioned it just now, but just where does this passion come from? I mean, knowing that you're bringing treatment options to millions of people, what made you get behind this so toughly?
I'm in the middle of 5 kids, so, I'm like always trying to, bring peace, to everything. And so for me, I think it was really just engendered by my parents about giving back and finding a way to make a difference in the world. I don't know if you guys know this, but I was an IT guy for 5 years with telecommunications industry. And then I decided that wasn't going to be enough, that I wanted to make a difference in the world. And I went back and got my PhD in neuroscience, and it was really wanting to do something that would be helpful to others. That was the driving passion behind my work.
I love it. We need a peacemaker in medicine at all times, so thank you for that. Be sure to ask your questions to our entire panel. You can use the chat on YouTube or Facebook, tweet us, email us at the Medical News Network. Info is right there on your screen. Let's get a check on our COVID count from Dr. Dane Hawkinson. Back with us from vacation. Are you nice and rested on this Monday?
Back briefly, yes.
Good, good. How are you?
I'm doing good.
Good.
I'm doing good. I understand it was pretty hot here. So, but right now, even though the temperatures are high, the numbers for active infections here are still staying low. Thankfully, we had 18 total right now, but only 7 active, 0 in the ICU, and 0 on the ventilator as well. So overall, circulation of the virus in the community is low. That is evidenced by the impact here with the low numbers of hospitalized patients for COVID-19.
Okay, I'm going to ask you a question, but guess what you have to do first?
Yeah.
Put your microphone on.
Oh, yeah.
That's right.
I've been away so long.
That's okay. You're out of practice. That's all right. I said it's like it's Monday, so we get to do that. I get to mispronounce things, and you don't have to put your microphone on. That's how it works.
All right.
Okay, while you're doing that.
Well, hopefully they heard me. 18 total, 7 active. So.
Thank you. Thank you for that. No big deal. I've been there, done that. Okay, so you've been following the new RSV vaccine that's coming this fall for people 60 and older. We've been talking about that. The FDA gave its approval last month, and then last week it was the CDC's turn to give the final seal of approval. But the Advisory Committee on Immunization Practices, ACIP, gave their approval with an asterisk. Instead of simply saying, go get the vaccine, the panel recommended talking with a doctor first, then get the vaccine. So why talk with the doctor first? Why not just go get it? That's what we've been saying.
Yeah, which we would always recommend you're talking with your medical teams and your physicians. This is more of a, what we've seen is called as a restrained recommendation. It's several reasons. Really, again, 65 and older, the vaccine is really, really good. It does help protect against lower respiratory tract. That means disease in the lungs, but also severe disease and death extremely well. For those that are maybe that 60 to 65, there is still really good protection. But the concern is there going to be a good cost benefit? We know that the prices for these vaccines will probably be around $200 or more, but that is not necessarily what you will pay if you have insurance. Generally, that will pick it up. But there was that cost concern by this group as well. There was also another concern for that population or those groups of people that have some sort of immunocompromise. There just wasn't a lot of data that they could look at for that. So it is more of a restrained recommendation. Overall, it does look very safe. There were obviously some side effects, and but as that vaccine is rolled out, they will be looking for more safety signals as well. But that is really what the restrained recommendation is about. Certainly if you're 65 and older, very good idea to get it. They were just concerned about the cost benefit, especially for those maybe that are under 65. But also we're looking for more data in those immune compromised populations. So that is why that restrained recommendation, and that can be removed or adjusted as well once the vaccine is rolled out and you have that real world data, because that will continue to go on just as we saw with the COVID vaccines. There is always that ongoing surveillance for efficacy of the vaccine, but also safety and safety profile as well.
All right, we hear you loud and clear.
Yeah.
Thanks so much. Any reporters with us today? All right, let's get to our community questions. We got a few good ones here. Sherry wants to know, Dr. Hahn, why women? Why do women get more?
It's a great question.
Or do they just put up with more?
Well, you could argue both,
Maybe both, right? Yeah.
But I would say there are certainly hormonal components. We know this. Migraines tend to be in younger population. For girls, migraine tends to come near the time of menses or shortly thereafter, and often gets better as we get closer to 50. So we know that there are components there and ties to the menstrual cycle for some women as well. So we think that that's a piece of it.
Oh, good.
Certainly.
More hormonal issues to deal
Yes.
with. Thank you for that news. Dr. Conway, how long did it take to develop gpant, and where did the name come from?
Sure. So, I started working on this around 2000. So, it was a multi-year effort, to bring something forward. I don't know if you know this, but drug discovery is a partnership between biologists and chemists. And so the chemists are breaking bits off of the molecule and adding bits on, and the biologists are running assays to show you whether it hits the target in the right way. And then they're looking at off-target assays to see if you're not causing a problem. And so it was, 10 years of improving and working and modifying to get a pristine molecule. There's only like 4 adverse reactions listed, in the package insert. With low rates of, taste disorders. I think it was 18% on drug versus 4% on placebo. And then, nausea or nasal discomfort or vomiting around 2 to 4% on drug versus 1% on placebo. So really well tolerated in general. And that's the result of more years of research and refining and doing it. And then also there's the cascade of sometimes, just like in your life, you change your plans. Sometimes companies change your plans. So I actually had to follow gpant through 3 companies, from BMS to Biohaven to Pfizer before it got launched. And so sometimes there's a component there, and it's actually just a difficult trail of a gauntlet, to bring forward a pristine drug that can have a benefit and see the light of day and become an approved product.
So the longer it takes, the longer the name. Tell us about the name.
Yeah, okay. So, so that scientists and physicians can communicate, when the new class of drug comes along, you get a STEM, and the STEM here is for gpants. And so in the United States, there's something called the United States Adopted Names Council, the USAN Council. So originally, maybe you don't know this, but originally it was gpant with a V first. But then when the World Health Organization's International Non-Proprietary Names Expert Committee, that's the INN, came along, they thought that worldwide it would be easier for other countries to say zavegepant than vazegepant. Don't ask me why. That's just how it laid out. And, It's supposed to be helping you communicate. Thank goodness that we have trade names like Zavspret, where we don't have to say all the other names after a while.
Right, and they weren't wrong. It is easier to pronounce than I'm done. I'm not saying it. Okay, I won't try. I'm good. I'm leaving that to you. Couple other questions. How do you know, Bruce wants to know, how do you know if you're experiencing a migraine and that it's not just a really bad headache? What's the test you put people through?
Oh, that's great. There's really no test. It's all based really on clinical information. So describing the pain, associated symptoms. So there are criteria that people meet for that. And that's where I encourage people to go talk to their doctor, because there are different ranges of what a really bad headache means to a lot of different people. And criteria matter on that one. So typically if it's, again, like Dr. Hahn mentioned, one-sided, really severe throbbing, and has some other associated features, that's going to be more of a migraine headache.
So Gene wants to make sure, Dr. Hahn, he heard you right. Did you say Botox, as in Botox? Botox is
Yes.
what is used for migraines. Tell us more about that.
Yep, it's exactly the same drug that's used for cosmetic. In fact, some dermatologists were using it for cosmetic, and some patients came in and said, yeah, my wrinkles look much better, but oh my gosh, my headaches are dramatically better.
Wow.
And so then Allergan, which makes botulinum toxin A, in the form of Botox, actually did some studies and found that it was incredibly helpful in reducing migraine. So it's FDA approved for chronic migraine.
Jeremy wants to know about this being covered for insurance. He says his wife has an issue that they've been bouncing back and forth between doctor recommendations and then insurance not covering different treatments. So how do patients navigate this, Dr. Ford?
I think that's one of the hardest parts. So every plan is going to be different. Every plan is going to change. And so I think talking with your doctor, they're going to know a lot of those details. Talking to your insurance company is going to be helpful. Knowing that you want to have that medication on their formulary, which is how they determine what they're going to pay for, is also helpful. And then a lot of these newer medications do have some copay processes in place where they can help when these are financially unaffordable. Unfortunately, some of the managed care plans with Medicare and Medicaid are going to be a little bit more difficult, but we still recommend that you talk to your doctors, because there are often ways that we can get around that.
Are halos and auras the same thing?
So visual halo can certainly be a symptom associated with aura, but it can also be something associated with the eye itself. So it varies, but yes, it can be part of an aura.
And lastly, Erin wants to know, can food spike a migraine?
There are certain types of foods that can trigger migraine, and it can really be varied. Red wine, chocolate, nitrates, and say preserved meats are kind of classic, MSG, but I've seen some patients develop a lactose intolerance that manifested as increase in migraine. So it can be almost anything.
It can be almost anything. Such a mystery, right, Dr. Ford? It is. Okay, so we want to get our takeaways today. Dr. Conway, I'm going to start with you and just tell folks when this will be available as a treatment option for them.
Yeah, so this is now in Pfizer's hands, and they said publicly that it's July. So we're on the cusp. So looking forward to that very soon. And I think for me it's just about giving patients control, because one of the things lacking in their lives is control. You heard of the unpredictability of the attack, and so we think that zavegepant is going to be a nice additional tool. When you're just hanging out with the family on the weekend, your regular treatment may be good enough. But if you're stepping up to something important, you've got a life event or a family event or a job event or something where you need 15-minute speed of onset, we think that zavegepant is going to be really helpful to those people where a non-oral situation, it can't be tolerated because maybe they're too nauseous to take it. So we think there's a situation here that can be really helpful and adds to the tool set.
Well, Dr. Conway, your insight and your life's work has been fascinating to learn about this morning. So thank you for sharing. We appreciate all the work you do.
No, thanks so much for having me. It's been great to be with you guys. Thanks for getting the word out. 40 million Americans, we need to help them understand that there are new options out there.
Thank you so much. From the Peacemaker, thank you. Thank you so much. Dr. Hahn, what's the takeaway? What do you want folks to walk away and know about their options?
This is a day to seek help. If you are suffering from migraine, really no matter how often you're suffering, or you're just suffering from headaches, you're not sure if they're migraines or not, this is the time to be evaluated. We have revolutionized the treatment of migraine. We have so many options now and combinations of options that we can get significant improvement in almost everybody. It's not unusual now. I walk into my clinic, into an exam room to see a patient. We prescribed medications and they say, "You've changed my life. I have a life now." And that is very rewarding, not only for me, but most importantly for the patient.
And I think the biggest thing I learned from you today is that so many people that have normalized it, and letting viewers know that you're not the only one.
Absolutely.
Don't normalize it. Let's lower that number of people who come kind of out of the shadows and say this is a real issue. Dr. Ford, what's the takeaway today?
Yeah, I echo all of that. I think the takeaway is, go and get evaluated, because there's no reason to suffer. And just because your friend has a headache and they say, "Oh, I tried this or I tried that," that doesn't mean that's going to work for you. And a doctor's going to help basically make a plan for you and your lifestyle that will work for you. And so I definitely recommend going in and getting checked out and coming up with an individualized plan for your life.
Thank you to all of our guests today, and of course our viewers, for being with us. Have a great day. We'll see you back here tomorrow, or Wednesday at 8. Coming up Wednesday on Open Mics with Dr. Stites. How do doctors respond when critical drugs are in short supply? I'm Jessica Lovell on the next Open Mics with Dr. Stites. How pharmacists, physicians, and patients fill the gap in the global supply chain, and which cancer patients in particular are impacted by this current shortage. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.